Okay, we're all good.
Right. Hello, everyone. Welcome to the first meeting of the new year of Health and Hackney Scrutiny Commission. We start with the election of chair. Can I have a nomination for chair?
I nominate Cllr Adams.
Seconder?
I second it. I second it.
Okay. Can we, any other nominations? No. Can we vote on Councillor Hayes as chair?
Agreed.
That's unanimous. Councillor Hayes, please take over.
And can I take, could I just ask all members present to make sure they mute their Google Hangouts? Because I'm getting some feedback on this. Thank you. Can I take nominations for vice chair, please?
I nominate.
I nominate Peter.
And Councillor Snell, and I have a second as well. Thank you. And so is that Councillor Snell is duly elected as vice chair. Thank you. Thank you, everybody. Welcome to June Health in Hackney. Apologies from Dean Henderson and Vinay Patel from the LMC. In terms of just the standard items, this is now a hybrid meeting. We have some members present here in the council chamber. Other members will be joining remotely, along with our guests joining remotely. The meeting is being live streamed and recorded. Please, can everyone mute their microphones when they are not speaking?
I'm sorry to interrupt, but the people in the room they don't need to unmute to speak. And when they do unmute, they all speak back.
I'm grateful. So thank you, Councillor Plouviez. For members who are joining virtually, when you please remain muted, but when you wish to speak, please unmute. For councillors in the chamber, just speak and don't adjust the Google Hangout. Thank you, Councillor.
Because they're not working. It's these green boxes.
And we don't use the mics. The press will be watching. Please keep your cameras on. Please do not use the chat function, unless just to indicate there is a question. Declarations of interest, none have been notified to me. Item 5 in the agenda pack, we've got the terms of reference for noting. That's there. I needn't go into any more details about that. Item 6, we need to appoint 3 members for Inner North East London JHOSC, the Scrutiny Commission. That is historically chair and vice chair. And I understand, Councillor Adams, you may be interested as well. Is everybody okay for those 3 nominations for INEL?
Absolutely, yes.
I'm great. Thank you. Then let's move forward to item 7, which is an update from the Homerton, particularly surrounding the Pathology partnership, which started on the 1st of May of this year. We particularly asked both for an update in this early stage to see how it's going, and also because there are some reports from the Health Service Journal about new requirements as the governance structure of the pathology networks and how this may affect our network. We've also got, obviously, Tracey here, the Chief Executive of the Homerton, to speak about that. And I think we've also flagged to Tracey that we might ask her as well about the news of the potential collaboration, as it's been called, between Barts and Barking, Redbridge and Havering, and where that leaves to Homerton, and to the extent that Tracey is able to also just give us an update on any preparations that may be underway for a new wave of COVID. So, Tracey, if I could ask you to speak for no more than, say, 7 minutes, and then I'll open it up to questions. So, Tracey, over to you if we can.
Hopefully you'll hear me okay. Apologies for the background. I'm just in London at the moment, so I apologise for that. It was like cutting out where I was receiving it, so hopefully you'll hear me in reasonable flow. So I'll speak very briefly. Firstly, on the pathology issue. So Councillor Hayter has correct in that the partnership went live on the 1st of May. We believe as three organisations that went relatively smoothly, albeit the large part of that go live was really associated with the transfer of staff from both the Homerton and from Lewisham and Greenwich over to the Barts Health employment and payroll in order to have a single staff group. That didn't mean that people physically moved at that point, and that will start happening once services start changing. But overall, I think the initial few weeks went reasonably smoothly, and as smoothly as one could expect. We're now in process of planning for the next stages of the coming together of services. The first step of that will be the GP direct access work, shifting to the main hub at the Royal London Hospital, and that is due to take place at the beginning of July. When that happens, some staff who are currently based at the Homerton will move with that work to the Royal London. Running alongside of that and concurrent with that, we at the Homerton have been developing the plans for the emergency services laboratory on site at the Homerton, and that was one of the key drivers. This partnership gave us the ability to really develop the laboratory services on site from the current probably inadequate provision that we've got that dates back to I think the initial building at the hospital. So we've gone out to tender for that laboratory, and we are anticipating building on site beginning later part of the autumn of this year, all being well, with a completion towards a similar sort of time scale, so late autumn 2022. The next service step after the GP direct access moving across at the beginning of July will be around mid-October, and that will be microbiology and virology, also moving to the Royal London main hub site. So I think there's quite a lot of, there's a huge amount of engagement from the team. There's been actually quite a lot of opportunity for particularly the Homerton staff as well, with regards to change of roles and new opportunities coming out of working in a different size of team. So there are, as with all of these things, there's always a degree of apprehension, but equally there's also some opportunities, and some of those opportunities are being realised now. That's not to say that this is something that we will and should become complacent about, and of course, as I've just described, the first step of going live was a relatively short step, and there are much bigger steps to come in terms of transfer and movement of activity, and we as a tripartite group of trusts need to continue to manage that as part of being owners of this venture, and the new strategic partnership board will be up and running, and all three organisations will be represented at executive level on the board. I think the only other thing to say is
oh, we've lost her.
Oh, we lost you, Tracey.
Actually, it's bad.
I think we've completely lost Tracey's connection.
Yeah. Maria, can you help, or is she trying to log in again? Hello? Oh, she's joined again. Hello, Tracey?
Hi, Tracey. We've got you back. Can they hear us, Charlotte?
They should be able to, yeah.
Hi, Tracey. Can you go again, Tracey?
She's back.
Oh.
On mute.
Tracey, you're on mute. Tracey, if you could just unmute. Yeah.
Hello, hello. Can you hear me? No, I'm
Got,
not.
yeah, got you back. Got you back.
No, I'm not. I'm not.
You are.
She keeps coming and going on mine.
You're coming and going.
Perhaps try to switch the picture off and see if that makes for a...
Can you hear me now?
You very vaguely. You came and then you went.
Can you hear me?
Yeah, just.
Would it be easier, Tracy, if you turned your camera off and just joined audio?
Can you hear me now?
Yes. Tracy, do you just want to carry on for a few more minutes and then I'll take questions if you can still hear us? No, we've lost her again. That is slightly frustrating. I think let's give it another minute, see if we get it back, or if not, I think we're going to have to. Oh, she's come back again. I can see you there, Tracy, but I can't. Do you want to try speaking again?
Mario's trying to call her.
Hello?
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 Hi, Tracy, we've got you.
She could call in on...
Yeah, can you hear me?
Yeah, I can hear you.
No, it's really bad.
You've gone again.
It's just catching up every now and then.
Okay, I think unless we get it back, what I will do is I'm just going to go around.
Can you hear me, Ben?
Yes, I've got you there, but it's slightly delayed.
Well, it just suddenly cut off. Right.
We seem to have you back a bit better now. Can you hear me now, Tracy? You've gone again. Okay, we've only got...
Right, okay,
Oh, hang
sorry.
On. Hi.
I don't
understand why she's not switching the camera off.
Okay. I've taken my...
Yeah, it's very disjointed, Tracy. Tracy, if you can hear me, I'll just try one thing. We've got about 10 minutes left for your item. Could you just forget the trying to do it visually and just phone in on your sort of mobile line, because then we might just be able to just do it that way as a last attempt. Members, what I'll do, if we don't get Tracy back in a minute, I would go around the room and ask any questions we've got, and then we can put them to Tracy by email and get responses that way. So I know that there were questions about the pathology lab and other matters. So let's just try give it one more minute here, and then I'll go around and then we can move on to the next item. Hi, Tracy. No. Do we know if Mario is trying to?
He is, yeah.
He's trying to call her. So I think the best, if we can just relay to Mario, perhaps the best thing is if she just phones in.
Yeah.
I'll just give it another minute or so.
What's the phone number?
While we're waiting, just because I like to pick on people, Mark. Sorry, I saw your attention there. Would you mind just saying, I'm entirely catching you on the spot here, but just while we've got a few minutes till we try and get Tracy back, there's a story at the front page of the local paper this week about GPs requiring ID and that possibly presenting a barrier to access. Have you read that story?
Excuse me, no, where was it published?
It was in the Hackney Citizen, published a few days ago.
I haven't, I'm afraid, no.
Right.
Yeah, carry on.
I don't want to ambush you with it to the extent that you're not prepared for it, but it may be that we can send you that story. I think it's some work that Healthwatch had done in particular. And then maybe next month you can maybe just provide us with some sort of response, whether it's just one practice or whether it's a policy across a number of practices. It was about ID being required and possible barriers.
I mean, I think there's been some work, I know, and that's been fed back by the Healthwatch report and has been heard at the primary care group within the ICP area for primary care. Parenthetically, I should just say that I'm no longer the clinical lead for primary care in City and Hackney. Dr. Kirsten Brown has taken on that role now, who's a GP partner at Spring Hill and the Lawson. Started that from April the 1st. But anyway, the regulations are clear that you do not need to present ID to register with the practice. So, but we can pick that up more substantively if you want to sort of pass me on the question and the article.
Yeah,
but I know that has been discussed with the Healthwatch already. They presented their findings, which have been discussed with Kirsten, Richard Ball, and I have been involved tangentially on that.
Fine. And so what was it, just a misunderstanding in the feedback Healthwatch were getting, or were there perhaps a few mistakes made, or do we not know in terms of why this story arose in the first place?
That level of detail I would want to check, actually, just so that I don't mislead you as to the different reasons why it came about.
Okay, thanks, Mark. Fine, well, that's certainly something we can do. We can liaise with Healthwatch and send you on the article just to make sure that has a level of scrutiny to it. Do we have Tracey back on the phone or any other means?
I don't think so, no. I think we might have to move on.
Fine then, in that case then, we've got a few minutes left on this item. Can I just go round the room and ask members, can I have one question each if you've got one from members that you would have asked to Tracey, and we can take a note of it, and then we can ask Tracey to reply by email. My question was going to be about the collaboration with Barts and BHRUT and where this left the Homerton and what the board's view and what her view was of that collaboration and the Homerton's position. Councillor Adams, did you have a question?
Yes, the question is about will there be any job losses in the long run in terms of socialism?
And that's to do with the pathology lab?
Yes.
Yep. Thank you.
When the mission becomes single integrated pathology network.
Thank you. Councillor Snell, did you have a question?
My question would be, have the concerns of GPs about poorer speed of response, poorer getting the data back, been borne out or not? And that ties into this idea that, according to the report, December 23 will be on a single network. I'd just like an explanation of why we didn't try and put the communications network in before we went to the new shared system. It sounds as if, it's being done in the wrong order.
Yep. Thank you. Now, let me just see. Councillor David, did you have a question?
No questions, Chair.
No question. And Councillor Plouviez?
Yes, just following on from your question, actually, which was about Barts Health.
Councillor Plouviez, can I just ask you to pause there? Tracey, is that you? Are you back?
Yeah.
Oh, we've got you on the phone.
Yeah.
Right, if you can hear this, we've got a question from Councillor Plouviez to you. So far away.
Yes,
Councillor Plouviez.
I can hear it.
Okay, well, it was following on from the chair's question about the closer working relationship between Barts Health and BHRUT, leaving the Homerton a very small part. But the supplementary question is, why was the pathology partnership with Barts and Lewisham and Greenwich rather than with Barts and BHRUT?
Did you catch that, Tracey?
I think was it rather than with Barts and BHRUT at the end?
Yes.
Yeah. So when we originally started discussing the possible partnership, BHRUT were satisfied and content with their own arrangements. Bearing in mind the discussions started probably now 2 or 3 years ago regarding this piece of work. Lewisham and Greenwich came in later, so ourselves and Barts Health had already determined that there was work that we could do together to both of our advantages. Lewisham and Greenwich were reluctant to go into the partnership in South East London, partly because the South East London solution was looking to work with a private provider, and they were very keen, as we were, to stay within an NHS family, and so hence they started talking to us and wished to join us. So it was mainly because BHRUT at the time were quite content with their own setup and didn't feel the need to join Barts Health and the Homerton, and Lewisham and Greenwich took the opportunity to align themselves with an NHS setup rather than going out to tender for a private setup, as has happened within South East London.
Thank you, Tracy. The other 3 questions we've got is Councillor Adams asked, will there be any job losses overall when the partnership is fully up and running? Councillor Snell was asking about the complaints we have had historically about slow turnaround from Barts, but as a second part to that question about the network not being in place until December, and why wasn't that put in place first now before the actual partnership got up and running? Isn't that the wrong way round? And my question was, in light of the news of the collaboration between BHRUT and Barts, where does this leave the Homerton as a small to medium-sized hospital with a super sort of conglomerate on its doorstep? And what's your and the board's view about that?
Okay, so with regards to the jobs, there were already a number of vacancies within the department. So in terms of individuals, it is not anticipated that there won't be sufficient posts for the individuals we have within the department to slot into. There may well be some shifts in roles as the format and the configuration of the department, or rather the combined 3 departments, changes. And as I said earlier, some of that may materialise into being opportunities for staff, particularly because they'll be working within a larger department with a greater scale of service provision and a different structure in which hopefully opportunities will arise more so than happens within a smaller department. But we're not anticipating any individuals in effect losing their roles losing their jobs, because we already had, and all 3 departments had a number of vacancies they were carrying. With regards to I think it's just setting up the network later than setting up the partnership. To some extent, we needed to get the partnership in place first in order to then get the team in place in order to do some of the work that was required in order to bring components of what currently exists in 3 laboratories into a single laboratory with a sort of main hub and spokes on the individual sites. So there was a lot of thought put into what was the order of how you could do things, and particularly when you needed a degree of expertise coming together to establish, instead of having 3 pathways or standard operating procedures, for example, you need to come together and establish a single SOP, then bringing the team together, getting the team working together, and as part of that, establishing the leadership within that team was deemed to be more helpful in then subsequently establishing the transfers of service that are going to need to happen over the course of the next several months. I think the building work and certainly the setup of the laboratory on the Homerton site, I don't think that's problematic in terms of how the partnership works. If anything, that only slightly delays our ability to make some final movements of services across to the hub. The final question. So what's the potential impact of the collaborative coming together of Barts Health and BHRUT on the Homerton? So I guess the very honest answer at this moment in time is ultimately in the very long term, who knows where all organisations will settle, but as it stands at the moment, the arrangements that are being discussed for Barts Health and BHRUT, and I can only talk in terms of any discussions I've had with the two organisations, particularly the two chief executives, is that they are looking to establish or appoint a joint or a joint in common chair, and they are currently going to go out to appoint the chief executive post at BHRUT. The intention, certainly in the first instance, is to try and establish areas in which the two separate trusts can work more closely together in a collaborative way to both of their advantages. There is, as part of working within an ICS, there is the opportunity for the Homerton and indeed ELF and NELFT to think about where we could best both either help them or gain for ourselves by working collaboratively as a three-way or a five-way set of organisations, and to some extent there is those discussions are ongoing and have been part of thinking about how we develop an ICS and what are the areas in which we may wish to collaborate. So, for example, some elements of procurement, particularly given the purchasing power of all three acute trusts, may well be to everybody's advantage. Equally, that case needs to be considered and thought through. So I think that overall the question of what we would want to collaborate with, particularly Barts Health, because practically our patients already flow to Barts Health. We already have clinical networks with Barts Health, and that is more likely to continue than the outer part of the sector, albeit that's a possibility. But where we can gain within the Homerton in working more collaboratively with Barts Health is to iron out any wrinkles that already exist within some of the clinical pathways, and where we already are dependent on working with Barts Health to ensure that we deliver a full range of clinical services. For example, we do not have inpatient urology, inpatient ENT at the Homerton. We have day cases, but we don't have inpatients, and so therefore there is already a relationship in how we work with them for those pathways.
Thanks, Tracy. I mean, I understand the areas of scope of working together, and that's always been the case, and obviously the ICS will accelerate that. But you can appreciate from a resident's point of view and from our point of view, we're incredibly proud and grateful for the work that Homerton does for our borough, and the idea that there could possibly be a merging of governance or management, and essentially a loss of the independence of the Homerton going forward would be of grave concern, and would undoubtedly be met with an awful lot of resistance. Have there been any discussions at board level of merging governance or management with Barts or BHRUT?
No, I mean, so clearly, I hesitate only because, of course, as a board, we've discussed the proposal of a greater degree of collaboration existing between Barts Health and BHRUT, and what that may mean for the Homerton, particularly in the context of the ICS, and that is equally applicable actually to potentially ELF as well. I only say that because I know Paul's in the meeting also, but no, as a board, we have not talked about there being coming together of governance or management between ourselves and Barts Health, and I personally would equally have some concerns about that, given the current position of the individual organisations. So at the moment, I think that the Homerton is in a pretty reasonable, robust state, and there are certainly a number of issues that both Barts Health and BHRUT, and I think they would acknowledge this, need to resolve, and part of their thinking about coming together is the opportunities that gives them to resolve some of the long-standing issues that they have got. Whatever, and individuals may have different their different thoughts about how successful or not that may be, but nevertheless, from the Homerton's perspective, I think we'd have to be very clear about what the case was to embark on any of those discussions. I will add that one of the things that Barts Health and BHRUT talk a lot about is the advantage that they see exists within City and Hackney regarding how the organisations have come together and the role that the Homerton potentially increasingly will play, and I suppose myself will increasingly play in place-based care. And to some extent, there's a degree of recognition that they are further away from where City and Hackney are in development of that way of working than they would like to be, and hold that up as a bit of an example of actually that what they'd like to do is follow what Homerton has within the place-based care provision and within City and Hackney as a whole. So there's things they can learn, and I think they recognise that from the way that City and Hackney have worked together, not only with regards to the Homerton, but as we all work, including with local authority partners as well.
Thank you, Tracey. I mean, we've obviously overrun slightly because of the technical difficulties, and I know you've got to go. This is clearly something we're going to want to keep a very, very careful eye on and be consulted on as it goes through. So any changes that give rise to further discussions about that, I think it's certainly something we would want to be kept in the loop on, and to be able to properly scrutinise, because I think our antennae is understandably raised about how the impacts it could have upon the excellent service, the outstanding service as judged by the CQC, the Homerton provides. I'll leave it there. I'll leave it there if I can. There was a question that you needn't reply to now, but you can send it through, or ask maybe Catherine to send it through, as to how many of the staff at the Homerton have had their first and second vaccination. You needn't answer now, but if you could possibly just send that through, or ask Catherine to send it through in the coming weeks, that would be much appreciated.
We will do. Thanks, Councillor Hayhurst, and apologies for the technical difficulties. I can't really explain why that was, but I apologise for that. And in answer to your question about coming back regarding any, well, as inevitably these discussions develop, I'd be very, very happy to do that. And I think this is something that we across City and Hackney should be interested in, and particularly as part of the ICS developments as well. So I'd be very, very happy to come back and discuss that. Yeah,
I mean, I think it's so important that I wouldn't want it to be discussed at a stage when it was a fait accompli. Just to put that red line down now, if I can. In terms of our involvement.
If I can come back on that. So of course, some of this is coming to me a little bit late as well. So as I understand it, I'd be very happy to discuss it. And one of the things I need to do is make sure that the leadership within Barts Health and BHRUT are including City and Hackney within their discussions as well.
Okay, we'll leave it there for the time being. Thank you very much for joining.
All right, cheers. Thanks, Councillor Hayhurst.
Thank you.
Thanks, bye.
We're slightly behind because of technical difficulties, but we will now move on to item number 8, which in the agenda, which is treatment pathways for long COVID. We have Dr. Fiona Kelly, who is the head of adult therapies and rehabilitation at the Homerton. Welcome, Fiona, and also Charlotte Painter, who is the work stream director. We've got a helpful presentation in the agenda, albeit it may be slightly out of date in terms of going up to March and there being estimated figures versus total figures that don't seem to make much sense. So if I could hand it over to Fiona and Charlotte, maybe for a 5 to 7 minutes presentation, and then I'll open it up for questions. Thank you.
Thank you very much. Good evening, everyone, and thanks very much for inviting us along this evening to talk about long COVID. So I think you've all seen the presentation, and we'll just be giving a few highlights, if that's okay to fit in with the timescales. I'm going to kick off, and then Fiona will pick up the kind of more clinical aspects of the service. So in the pack, we start off with the nice definitions associated with COVID and post-COVID and long COVID. And I think the point to pick up here really is that in creating our service, we really tried to consider the needs of people at all stages of this disease, which is obviously a novel disease, and not just those who require access to the specialised service. So I think it would be true to say that we're really seeing long COVID as kind of a new long-term condition, and that's the way that we're trying to build the approach and kind of use that concept. The data slide that you alluded to does show some estimates of demand. It is a little bit out of date, but I think it is true to say that we have experienced a spike of referrals in March, which was anticipated following the kind of Christmas surge in COVID, obviously. And we, as you will see from the paperwork, we've built a dedicated pathway, and we have tried to build capacity to respond to the needs as they present. It is obviously a moving picture, so that is quite challenging in itself. Then our approach to this work has been from the beginning really to take a system-wide approach, and I think this collaboration between system partners is really one of the key strengths of this programme, and this has included work sort of with community services, and also close working with residents who've experienced long COVID, who have helped co-design the service and have been really very helpful in putting together our service. And the aim of the service is really to ensure that people are directed to the right care pathway. And primary care is really integral to that process, and Fiona can kind of take you through the pathway. But we have been keen to emphasise in creating this the sort of education and skills building for self-management approach. And you can see some of the resources that are available to support people who are managing this condition, which is on slide 5. And many of those have been created by our local team and have been circulated nationally, and people elsewhere have picked them up and used them. And that happened very early on with the ACES team creating those resources. So I'll just hand you over to Fiona now, who can pick up the clinical aspects.
Thank you.
Thanks, Charlotte, and thanks for the invitation to give an overview. So Charlotte says it's been very much a system collaboration in designing the service, both across partners, but importantly, as Charlotte mentions, with patients. And you can see in the slide pack some of the direct feedback from patient experience of patients that have started to come through the service. Very much supporting primary care in terms of the information resources that Charlotte has flagged to support people when they are presenting and being supported in primary care. But in terms of accessing the pathway, the specialist assessment clinic, but also the community-based rehabilitation service, that is through GP referral, and that's specifically for patients who are meeting those kind of nice criteria. So they're having persisting symptoms 12 weeks or more, and also they've had a comprehensive assessment within primary care with their GP, and that's to make sure that actually we're not putting people through the long COVID service that actually may have some other medical condition that requires investigation, or actually putting moving on to an alternative pathway. So we have a single point of access. You can see the pathway there on slide 6, that all referrals come through primary care. They're then clinically triaged, and dependent on that, they will then either go directly onto our information giving and treatment commencement initial assessment in the community-based service, or they'll come through for a further specialist assessment, which at the clinic is based at the Homerton. We have given you some indication of sort of numbers coming through. As soon as you do the slide, though, the data is refreshed and updated. So to date, we've actually received around 300 referrals across the service through to the assessment clinic and to the community-based service. We've completed actually 95 assessments in our assessment clinic and around 40 assessments in our community service. I should say that not all of the referrals coming through are initially appropriate for the service. We have had a number of out of area referrals, and obviously, as you know, regionally a number of long COVID services have been stood up. So where another service exists more local to the person, if they're not a City and Hackney referral, we've been redirecting those. We also do track the ethnicity and a number of other things regarding the referrals that are coming in. And we are, obviously we flagged there on slide 8 that we are concerned that this isn't as representative as we would be anticipating for the local community. So we've got a number of future plans in terms of proactive case finding and working with community and charitable organisations to try and support people to access the route, which is via GP. And obviously there are barriers and concerns around that. We were asked specifically to give a bit of an indication in terms of symptoms and impact of long COVID. You can see this is directly from the patient feedback, that it's a really wide range of symptoms that people are experiencing, but the most common that are often a feature is around persistent fatigue, which is really debilitating, and also breathlessness. The impact is also far ranging, so certainly affecting people returning to work, looking after themselves and others, and also their psychological well-being and management of relationships. It's, of course, a novel condition. We're continuously learning and developing the evidence base and doing that through collaboration. We're involved in regional and national work around developing clinical standards and building consensus around what might be some appropriate outcome measures, etc., to continually inform. However, we can draw on our experience and expertise from other long-term conditions in terms of treatment, and a key treatment is certainly lots of education and information giving and supporting people around fatigue management and energy conservation. There is a risk of people attempting to do too much too soon and actually experiencing further a relapsing and remitting course. So it is really important that this is quite a skilled, clinically led intervention with patients to support them. We're also, I suppose, the only other thing to highlight, so very much a very diverse multidisciplinary team across physical and psychological health, and we're also using digital technology to support patients, which is some new ways of working as well, so using a specially developed Living with COVID app. I'll just hand back to Charlotte if there's anything in terms of future further points to flag, Charlotte.
Thanks, Fiona. Yeah, so just on the sort of final slide around next steps, our aim really is to try and build a sustainable service which is led by allied health professionals, and that links in with the other work that we're doing locally around the neighbourhood footprint. We do need to do further work on awareness raising and engagement, as Fiona has sort of alluded to. Fortunately, we do have secure funding for the coming year, and we will need to just kind of monitor the demand and the presentations as they come through, so that we can plan ahead, beyond that point, really. And I suppose the final point just to mention is that we have created a clinical fellow post across North East London, and they will be helping us with evaluation of the service, which I think is a real plus point as well. Thanks very much.
Thanks, Charlotte. I mean, just before I open up to other members, Fiona, if I can, I mean, if I've had COVID and I'm suffering from some of these symptoms, having to wait 12 weeks, going through possibly quite significant discomfort or pain before I can then even access the service, because I haven't then met through the pathway. I can imagine that being immensely frustrating. I mean, do you agree with this NICE? Has the NICE guidance got this right? Should there be greater support at an earlier stage?
I think, yes, thank you for the question. I think what we're knowing is that although absolutely distressing and ongoing symptoms and very frustrating, but actually a large number of patients will resolve within that initial post-acute phase. So obviously this is trying to get the balance right in terms of supporting people who actually don't resolve and need it and need that specialist input, and those that actually with some pointers, and actually the resource information is very comprehensive, quite interactive as well. And actually some people were just following some guidance in terms of gradually returning and increasing their activity levels may be enough to meet their needs and follow that self-management approach. We are very open and through there is some leeway. So certainly within the local service, if a GP was particularly concerned that actually this was a person who didn't show any sign through regular review that they did seem to be someone who did need some additional advice, that we would consider an earlier referral and support and advice and guidance from the service. So I think it is really challenging to choose what is the cut-off, but that was based on best available evidence, and largely we are supportive. That does seem to be mirroring the clinical presentation that we're seeing.
Okay, thank you. Other members, Councillor Snell?
Thank you. We know when we were at peak numbers at Homerton of COVID patients, it was really important that they were there rather than the mass hospitals, because they were often being treated for multiple conditions. People had underlying conditions that were made worse by COVID, and they needed support from their normal specialists. The way you're presenting this to us, it sounds as if it's a rather standalone process. And I'm assuming, and this ties in with Ben's previous question, I'm assuming if people have complex medical diagnoses, then they're not going to be left sitting around for 12 weeks. And I'd also assume that they are being given advice on how long COVID may impact on their other conditions. Could you just talk us through that, please?
Yeah, absolutely. So very much there is some established processes. So if someone, the point of the single point of access is that if the referral comes through and actually it looks that it's clinically triaged, if that person is clear that actually they'd be better supported either through an existing, if they're known, so obviously we know, as you've rightly pointed out, a number of people had pre-existing long-term conditions, often multiple long-term conditions. If they're already well known to a team, whether that be through secondary care consultant or through their community-based service, we would redirect that referral so that they are going to the most appropriate team to meet their needs, and also they're having appropriate further investigations or specialty, because as you've rightly pointed out, COVID is very diverse and it's a multi-system condition. We also have established an MDT, so if we're a bit unclear as to where someone's needs would be best be met, there can be a clinical conversation about how best to do that.
Multidisciplinary team.
Yes, a multidisciplinary team. So I think the logic, though, in standing up some separate standalone capacity, we do envisage this as as Charlotte's pointed out, it is essentially a new long-term condition. But I think our concern was if we were to simply badge all of these patients onto existing services that are obviously going through a recovery period as well, having had to redeploy staff to support the critical care response from some of our community services, we would have been overwhelming those services, and indeed the waiting times to support people with long COVID would have been even longer. So it's very much a transitionary situation that we've done this to support and understand the need, and then we would need to look for longer term, how do we integrate this service even further into our current range of services. I don't know, Charlotte, if you want to add anything from that.
Thanks, Fiona. Yeah, I mean, I think you've kind of covered the key points, really. I think, perhaps the diagram doesn't necessarily give it justice, but, the team is very linked into the relevant specialties and can seek advice, from cardiology or from, whoever is the most appropriate clinical specialty. So I think that is currently working well. Yeah.
Okay. Any other members for questions?
I've got a question.
Cllr Adams.
Yeah, I've got a question. It's not really about recruitment. The question is, and the people who did not have symptoms when they were infected have a long post-COVID condition.
Fiona, are you able to assist? So if you're asymptomatic, have you had any cases of asymptomatic COVID but then present symptoms later on?
I don't have the detail. I'd have to go to the service to ask that specific question. I'm sorry, I can't off the top of my head think of a particular case of an asymptomatic but subsequently presenting with long COVID. Apologies.
Yeah, thank you.
I think it is. Sorry, I think it's fair to say though that the severity of the initial presentation is not necessarily linked to this kind of long COVID symptoms and severity, and I think that evidence is coming through quite strongly. So it's not really a predictor of the kind of later sequelae. I don't know about the asymptomatic.
Councillor Plouviez?
Yes, I wanted to ask about that because there are in this cohort of long COVID, there are people who've been through very life-threatening and hospital treatment, intensive care, extreme illness, and then after in a sense after 12 weeks haven't recovered and still have symptoms, and those are one kind of cohort. But then there are definitely people who are appearing with some quite alarming symptoms, who were much younger and only had just a bit of a cough and a fever, were absolutely fine, but then suddenly have terrible skin issues or kind of different, all sorts of different medical reactions. That may be relatively rare, but it's a different thing, isn't it? And I wondered if we were following that or just how much there is of that.
Yes, that's completely right. So we've got two very different cohorts. So we've got the post hospitalisation, the people who've had a very serious illness, have required a period of acute critical care or ward-based care. Those people are often actually followed up through a different pathway. So if they've required intensive care through our post-ICU follow-up clinic, and also often will actually, because their needs will be so profound and they've actually required a period of inpatient rehab, they're often going through our existing pathway in terms of supporting them. The people coming through to the sort of the single point of access are more the latter, the people who are actually presenting into primary, who are less likely to have required an acute admission, but actually have recovered with support in the community, but actually, like you say, now have some very debilitating and long-term symptoms. And that is why the profile in this cohort, I think the average age was around 44, actually. So obviously working age people, and it's having a really significant effect on their day-to-day lives.
Thank you, Fiona. Councillor David, do you have a question or?
Gilbert's one.
Yeah.
Yeah. Can you hear me?
Yeah, we've got you.
Yeah. Essentially, my question is about healthy lifestyle. So there are some people who obviously wouldn't take the vaccination for whatever reason. I've taken mine, just to be clear. Peter was there when Councillor Snell was there helping out when I took my second one. So there are people who would not take the vaccination for whatsoever reason. Is there any way we are trying to promote them to have a healthier lifestyle? So we don't necessarily need to single them out, but then generally to tell people, ways they could keep themselves safe, probably encouraging such people to, I don't know if they can register somewhere or have regular tests, or I don't know. What do we do apart from, in relation to those people? And this might also apply to people with long-term symptoms. When people recover from COVID, do we just, leave them on their own discharged, or do we kind of follow them up?
I'll sort of take the point around sort of promoting healthy lifestyles in general. I mean, across all of our services, we like to follow the principle of making every contact count, really, with people that we see, and promoting and providing information. I suppose it's information and education for people to make informed choices, but certainly part of recovery from long COVID will be supporting people to look at their nutrition, look at their sleep hygiene, you know, look at the choices that they're making. Of course, we can provide education and support and information, but the choices are still with the individual. In terms of, I suppose, the follow-up, in terms of hospital discharge, it's very much on a needs-based basis. It would be very difficult to provide a sort of a prophylactic or a preventative follow-up for everyone, regardless of need. But certainly we routinely, we've developed a lot of really useful resources that we can use to continue to support people. But of course, their first port of call then, if they did have an unanticipated further need, would be via their GP to access further services.
Thanks, Fiona. In terms, I mean, I've come across residents in my ward who may have got COVID in the first wave, been to see their GP, wasn't able to assist them, maybe because your system wasn't in place or set up at that stage, and sort of feel they've got nowhere to go. To what extent is a communication drive needed to let residents know that this service is up and running, the referral point is via your GP? Has thought gone into a communications programme?
Yeah, thanks. I can take that one. So I think that's, you know, a fact that we are quite well aware of. And one of the things that we are planning to do is a proactive contact by GP practices to those patients who are registered and have a code of either COVID or suspected COVID. And this also speaks to the kind of health inequalities point, because we are very conscious that, you know, we appear to be missing a cohort of people here who haven't presented, who potentially are struggling and have needs. But that is quite a large number of people potentially, and so we've got to balance that with kind of not overwhelming the service, so we may need to do some sort of staged approach. But that is one of the things we are planning to do. And then I think the other thing that we do need to do, as I mentioned, is really more communication and engagement via community groups, because I think, you know, there's also potentially quite a lot of people who, you know, for whatever reason don't generally access their GP or healthcare in general, and will need some sort of encouragement to come forward and kind of have that sort of clinical discussion. And that's really where we'll be looking to work with our voluntary sector partners who have, you know, much better reach into those communities, and looking, you know, towards the kind of culturally competent engagement type approach that we hear about. I think that is quite difficult to pull off. So, I mean, that is one of the things that we'd probably appreciate any input from you and your residents around. If there's, you know, any ideas around how we can best achieve that, that would be great.
Yeah, I mean, it may be that it's worthy of a sort of a join up with maybe the efforts that are going on the vaccination side, in terms of, I'm sure, I mean, Catherine Kennedy might know better than I, but I'd be hoping that we're at a point where we have sort of a blueprint of how we network out to different community voluntary groups that we do when we need to, and then whether we could almost give you that blueprint framework to assist you to do so. And if we haven't got that as a council, I would hope we'd be some stage in developing it, both in terms of encouraging vaccine take up and an outreach here and across many other areas. So it may be that is something we can follow up later. Just one more question, if I can. In terms of training GPs and educating GPs, what work are you doing there? Are you doing training sessions to make sure they're fully up to speed so they can spot the symptoms?
Yes, we are. We've done quite a number of training sessions, and from quite early on, because as you kind of mentioned, in the first wave, we were getting quite a bit of feedback from GPs that patients were sort of presenting and they weren't really sure what to do with them. So even before the service was set up, we ran several education sessions. We produced a resource pack with some of the self-management resources that they could pass on to people presenting, and that process is really ongoing. So, you know, as we've said, this is really an evolving picture in terms of how we manage this disease, and there'll be kind of more and more learning that comes out, and we will continue to engage with our GP community, and they have obviously been very engaged and very interested, because it's, you know, it's a very pertinent problem that's landing on their doorstep on a daily basis. So we've had great take up of that as well.
Thank you. I see Siobhan's just messaged to see the vaccination efforts been using the community champions and voluntary organisations. So I don't know if, to the extent that it hasn't happened already, whether Siobhan can sort of pass on details as to how best we've learned to undertake the outreach work. Councillor Snell.
A simple question, I think, and I simply don't know the answer, and I don't think it was in the presentation. If someone presents with long COVID, do you do an antibody test? And does everyone who presents with, can you have long COVID without evidence that you actually had COVID in the first place? Is that part of the way of identifying it, and is it 100% reliable?
Well, I won't. I'm not a doctor. I'm not a physician. I'm an occupational therapist. So I won't seek to sort of try and get into the physiology of it. However, I suppose what we accept people into the service based on a clinical. Obviously, in the early stages of wave 1, we didn't have routine testing, of course. So we accept people into the service who have been clinically diagnosed as a presentation of COVID, as Charlotte mentioned. So people recording on the GP as either having presumed COVID or having had a COVID positive test. So we're not routinely doing antibodies on that. We're basing it, the referral, based on the primary care referral, the clinical assessment within primary care. There may well be some published research, or an area, there's obviously multiple areas of research and interest in this. It's not something I could comment further on.
Okay, thank you, Fiona.
John's got his hand up.
Oh, John, thank you, Councillor Snell. John, you had a question?
A couple of points. Firstly, on the development of the service, Healthwatch was involved in the first quarter of this year to support in that development, and that ceased. Is that going to be revived again? So, because we're really eager to kind of make sure this service has proper reach into the community. And the second point is on disabled people. It's not clear from your data you've identified how many people who had pre-existing disabilities in the who you're seeing at the moment. I'll be interested to know that, because we understand that disabled people have been one of the worst impacted communities by COVID. And I also want to know if you've been in contact with adult social care in terms of kind of contacting the home care services and finding out about the people in those services, because I suspect there've been high levels of COVID there. They would need to be long COVID there as well. Thanks.
Thanks, John. I'll make that the last question. So not sure who would like to answer.
Thank you. So on the Healthwatch point, yes, very much so. I think you know, as I mentioned, we do need to kind of ramp up our engagement work, and we'll certainly be coming to you for some help in that department, if that's okay. The disabilities data, I don't know if Fiona knows the answer to that. I'm not aware whether we're collecting that data at the moment, but she may be able to respond to that. But I'll just quickly talk about the adult social care and the home care, and that is a very good point. I mean, we have had involvement from adult social care in the kind of design of the service, and talking about sort of care packages and so on that people might need, or changes to those. But the home care point we haven't specifically picked up, so that would be another thing for us to look at in our proactive search, I think. Thanks.
Yeah.
in terms of the point around recording people with disabilities, in the setting up of the service, we actually did a detailed clinical audit tracking people who were with COVID and those who had pre-existing long-term conditions, to help us understand what the needs would be and the kind of configuration of the service. I don't think it is something at an audit level that we're like routinely prospectively collecting, although of course it's readily available information because anyone referred to the service, we have their clinical record. So it is something we'd be able to access as a point of research or audit in terms of understanding, and we'll pick that back up as to whether that is actually one of the regular stats that we should be reporting on as alongside the others. Thank you.
I'll draw this item to a close. Thank you both for your hard work and coming today to answer our questions. Very much appreciated. And I think depending on how things pan out, it may be that we ask for I saw Mark with his hand up there. It may be that we ask you to come back at some stage in the future. Mark, very quickly if I can, because I'm just going to bring this item to a close.
It was just about the antibody testing point. I just checked the UK Gov website just to see if their guidance has changed. It hasn't. One of the problems is that you still have people who've had a COVID infection who don't show positive results to their antibody testing. So for those that do show the test positive, well, it just probably confirms what you already know from the symptoms and the history of the fact they've been unwell with it, and a positive antigen test down the line, etc. And those who don't suddenly go, well, what are you going to do with me? Does that mean I can't come into the service or not? So no, you do, because you work on the history and the fact that you've had 12 positive tests, etc., etc. But the science is evolving and they're still working on it, but that's where we are at the moment.
Thank you. Thank you, everyone. So with that, I'll draw that item to a close. And then if I can now move us on to item number 9, which is community mental health transformation and recovery. We're grateful to be joined by the Chief Exec of ELFT, Paul Calaminus, and Andrew Horobin, who's the Deputy Borough Director for Hackney and City ELFT. Thank you both. We've got 2 sort of separate presentations in the bundle, one in terms of the impact COVID has had on services and how services has been interacting with patients, and then a second presentation about the neighbourhood rollout within Hackney. So I don't know whether Paul or whether I'm going to you first. Can we hear you, Paul? We're having problems. We're having problems before. I tell you what.
Councillor Hayhurst to introduce the item if you want.
Yeah. If you could, Andrew. So suggestion, Paul, is if Paul, if you're having problems, maybe do what Tracey did and call back in on the landline if you can hear us, because then we've got you quite clearly. So Andrew, over to you.
Okay, thank you. So yes, I'm just going to give a very brief introduction to the items that we were asked to discuss. I think it was generally in 2 sort of items: one around COVID, the impact that COVID had on services, and our sort of plans going forward for the community, and then also, as you've said, just how our neighbourhood mental health teams are progressing the community mental health transformation that's underway in City and Hackney in ELFT at the moment. So I thought I'd just really highlight a couple of points and then leave the bulk of the time for yourselves to sort of ask questions and probe us. I think the first thing I think that we would like to highlight is the impact on services of I suppose of COVID and the mental health impact that's had on us. And it's been really interesting actually. After the first wave, we actually saw a real reduction in the referrals to our community mental health services, and we saw a reduction in admissions to our inpatient mental health units. I think for similar reasons why we're seeing fewer people going to A&E, and obviously there was a lot of hidden need that people weren't contacting services for. However, the service that really did get the bulk of our referrals was our crisis line, and as you'll see phone calls to our mental health crisis line doubled, more than doubled actually, in the first lockdown. And although it's dropped a little bit, it's still a lot higher than pre-COVID levels. And most of the calls that we were getting were from people that weren't really known to mental health services before, and mainly calls around anxiety and sort of low mood and depression. And this was really due to sort of socioeconomic uncertainty, social isolation, and fear really of COVID and of becoming physically unwell. And this necessitated obviously a lot of work for our team. In fact, our community crisis services were the only service that stayed 100% doing home visits during COVID. All of our services did home visits, and I think I've put in one of the papers sort of criteria we use as to when we would visit someone at home and when we would do a digital or a telephone contact. But the crisis service, obviously, by nature of what it offers, needed to be able to visit people 7 days a week throughout the pandemic. And obviously, because the crisis line was getting all of the calls, this is the service that was the busiest and still is very, very busy as well. So that was sort of where the bulk of our I suppose mental health input was seen during that. Obviously, we go on to talk in the paper about the expected I suppose outcome or the expected cases that we're going to see, and I think it's widely held that we're going to be expected 20 to 30% increase really in mental health presentations throughout this period, but it is unpredictable. I mean, it's very, very difficult for us to tell where the need is going to be, but there's no question that the need hasn't yet in some of our areas fallen back to pre-COVID levels. The other area that we saw an increase in our children and young people services as well, and this is possibly also to do with homeschooling, so people not being in the family or being at home, and we're hoping that would perhaps also the increase would settle down as schools have returned. So that's the COVID mental health impact. In terms of the community transformation, I mean, obviously, I haven't been back to this committee for many youars, so I'm assuming that you're aware of our community transformation and the neighbourhood.
We are. Yeah.
Thank you. So really, it's just to give you an update, really, and the presentation does give you a bit of an update as to what's going on. So we've now got all of our 8 neighbourhood teams in place, and this has been over the last sort of 6 months. We've continued the transformation work. It was put on hold for a good while during the pandemic, and staff actually were redeployed into our crisis services. But for over 6 months now, we've been working back with the transformation. So our 8 neighbourhood teams are configured within ELF, so we've got the staff there, and the last couple are due to join with the GP practices by late summer. So the expectation is that sort of by September, October time, we will have our full blended teams. The feedback we've been getting from GPs has been really positive, particularly the ease of access and the responsiveness of our team. So as you probably know, there are daily referrals meetings and weekly clinical meetings. GPs are able to drop into those whenever they want to, and I think they really appreciate the opportunity not just to send in a paper referral form, but to have a good discussion about the service users that they're concerned about. And obviously, because we now have bigger blended teams, so teams that, as well as including all the professions that we have in ELF, so medicine, nursing, psychology, as well as social work. We also have the voluntary sector. We have Turning Point attending some of our meetings, so we have the substance use input. We've also had the Tavistock and Portland that come occasionally to some of our meetings, and we've also getting increased collaboration with James's Place as well, the charity that's about to set up for suicidal men. So the teams are far more diverse in terms of not just in what they can offer, but also in the advice and the discussions that they can have. And one of our innovations really in our neighbourhood teams is the community connectors role. So we now have community connectors in place in each of the neighbourhoods. These are posts that we have in conjunction with the voluntary sector. So they work for the voluntary sector within ELF. And their role really is exactly that. It's to link people back into their own communities not just to signpost, but to sort of go with people through the various stages of the journey to get back into their own community services. And actually, we're finding now more than ever, with social isolation having been so bad during COVID, that these roles are really, really important. And I suppose the only other thing to add that Paul can perhaps speak a bit more to, though, is about the plans to work with Healthwatch to gather views on the temporary move of our dementia inpatients to the East Ham Care Centre, and I think the plan is to do that, work with Healthwatch, and then report that back to this Scrutiny Committee in October, when we've got some feedback around that temporary move that happened during the pandemic.
Thank you, Andrew. I think Paul's now back with us on the phone. Paul, did you want to add anything on that?
So, I mean, thank you, Andrew, for that, and apologies for my technical incompetence, I think it must be. So I think all I really wanted to have added or emphasised, perhaps, is what I do think is going to be the importance of the community model going forward, and particularly with some of the referrals that we are seeing, that do really feel related to people's worries about housing, about money, about employment, and all those kind of social drivers that obviously really are creating significant distress for quite significant numbers of people. And then to emphasise, if I might, the point Andrew made there at the end, in terms of really wanting to work to make sure we properly understand people's experience in terms of the temporary move of the older adult ward, so we can properly report back to this committee in the autumn. Thank you.
Thank you, Paul. I mean, obviously we'll have a more fuller item on that. I think a number of us are fully versed with the movements from and to Mile End over the last 10 years. I mean, obviously a key concern has always been as to whether there is actually a reduction in bed capacity. And I think we've had previous examples whereby capacity levels were at X, and we were being asked to give agreement to go to much fewer beds when there were more patients in the existing ward, which we found wholly unsatisfactory. So clearly that is something we'll be looking at carefully. I think a number of us have visited both sites now on multiple occasions, so we're aware of the different dynamics and arguments there. Members, can I open up for questions if there's any at this stage? Councillor David?
Yeah, thanks for the report. My question is in relation to the managers' hearings, the associate hospital manager hearings. Say, for example, I think there's a new court ruling where hearings cannot be done remotely. So where you have pressures on numbers of people on perhaps community treatment orders, how is that being done? How's the impact being? So are the assessments being taken to the service users at their places, or they have to be, brought in? How is that impacted?
So we have been carrying out We've been carrying out assessments face to face. We did have a brief period where we were using some remote assessments for some of our community treatment orders. As you rightly say, there was then a court ruling that said that assessments needed to be done face to face, so assessments are now being done face to face as they were being before COVID. And then we've obviously been in contact with each and every service user who had a remote assessment to inform them that we, as the court has found, we, along with many other mental health trusts, should have done face to face, and that assessment is not in fact valid. And we've then had to work with individuals to make sure there are appropriate plans in place to support them properly.
Thanks, Paul. And just on the sort of the question of sort of mode of contact type, we've obviously got a helpful graph in here, bar charts. Obviously, with the increased number of calls to the crisis line, we see those numbers going up. I mean, what's the feedback been in terms of that and video as a means of communication? Obviously, everyone's different, but vis-a-vis the more personal and face-to-face, where do you see the service being in a post-COVID world with respect to the blend of electronic or face-to-face?
Yeah, I mean, maybe if I say just a couple of things and ask Andrew to say a bit more from the team perspective. I mean, I think in terms of the question about post-COVID world, I think we'll find ourselves in a more of a blended service model, to be honest. I think we've certainly reaffirmed actually the importance of face-to-face first assessment appointments, for example, the importance of seeing, you know, people who really need a face-to-face personal contact, face-to-face and in person. At the same time, we've also discovered, I think, if I had to generalise, that there are certain types of therapy, for example, that work really well online, and where you get really, really positive feedback from people who are able to stay at home in the comfort of a familiar surrounding. But perhaps if I stop and ask Andrew to add a few words.
Yeah, no, I agree, Paul. I think certain services, the service users have preferred it. So our early intervention service, younger people, some of the people in our autism diagnostic service, and certainly in our psychotherapy services, I think a lot of those have been, and our service user network as well for crisis, have really embraced that. But we're very mindful of digital poverty. We're very mindful of the fact that people may not have devices, although we've done a lot of work to get people devices now with our personal health budgets, and also that people are able to use them or might not want to use them. I think we will have a hybrid service. I think there are certain advantages to telephone and digital working. It means that we can communicate with people more quickly, more easily. But the fear is, of course, is that we really do need, particularly in mental health, to establish that relationship and that rapport. And also, we actually need to physically see the conditions that someone's living in. We actually need to physically see their environment as well. So there will always be face-to-face work, and I think that will probably be, for our sort of community mental health teams, our crisis teams, I think that probably will be the bulk of our work for those people in greatest need, perhaps outpatients appointments, perhaps psychotherapy, autism. I think that's where we may see more and more digital working, but there will be a hybrid, and that's just my opinion and my view of how things will be, but definitely a hybrid going forward to a certain extent.
Thanks, Andrew.
I suppose if I might add just one more comment, is that one of the pieces of work that we have kept going through the COVID period is trying to design this with our service users, so that this is a model that we keep iterating and keep designing together.
Yeah. Fine. Are there any? I mean, I've got some more questions, but I'm go to members first. Any more questions? Cllr Plouviez?
Yeah, sort of three-part question. The first question is about the pioneer sites. You've got 4, and then it says plan to roll out to all neighbourhoods. Is that coterminous with the PCNs, the APTNs? So is it based around the same structure as the existing one? The second part is the community connectors and the social prescribers. Are they employed by the health service, or are they employed in partnership with the voluntary sector? And how does that? And what is the difference between a community connector and a social prescriber? And the final one was we often, as councillors, meet estate officers and housing officers who tell us their main role is supporting people with their mental health needs. How does the service relate to training and supporting some of our housing staff?
Thank you, Cllr Plouviez. Andrew, did you want to go on that?
Yeah, so regards the pioneer sites, so what we've made a decision to do now, you're right, we have 4, I think we've probably got more than 4 neighbourhoods now that are actually working actively with the GP practices. But what we realised sort of about 6 months ago was actually we were, in terms of our staff groups, because as well as transforming the service to work closer with GP practices, we're also transforming the whole of our community mental health service as well, so our CMHT recovery teams as well. So in order to that work, we really needed to get all of our 8 neighbourhoods structurally in place internally. So our 8 neighbourhoods are internally in place. So our ELF staff and our community connectors are now in place. And I think we've got 2 more sites where we're yet to bring the GPs on board. So that's how we're doing it at the moment. So we've opened all the sites up just to ELF employees, internal referrals, and I think in the next couple of months, the final 2 sites will be open to GPs like the other ones. So that's what we're doing in relation to that.
Yeah. So Councillor
Actually coterminous with, sorry, there's 8 PCNs, so are your 8 match the 8 PCNs?
Oh, sorry, I misunderstood you. Yes, they do. Yes.
Great.
But how do the 4 pioneer sites fit in with the 8? I'm still a bit.
So what was happening was that so 4 pioneer sites were also coterminous with the four PCNs,
right.
And so we basically were bringing in one neighbourhood at a time. We gradually built up until all of our 8 neighbourhood teams were on board. That's how we actually developed the model. So brought in 4. We've now got all 8 of our neighbourhoods in place, and then only the last 2 will be working together with the GP surgeries by this late summer. So we have all 8 in place now.
And in terms of Councillor Plouvier's other 2 questions, in terms of how the community contactors differ from the social prescribers and who employs them, and about the training of the housing staff.
Yep. So in terms of the community connectors, so we are actually subcontracted that out to the voluntary sector. So it's a voluntary sector that employs them with the overview with ELFT. So in City and Hackney, it was Mind that took to appointing the various connectors that we have in each neighbourhood. So we have connectors that work for Derman, that work for Bishop Holim, that work for various other voluntary sector organisations under the umbrella of ELFT. But the difference between a community connect, I mean, this is a question that does come up, and there's so many different titles of jobs, and it is quite confusing. The community connector can do some of the work of a social prescriber, but they're very much also someone who will be doing some therapeutic interventions themselves. Our expectation is, and it's happening now, is that they will be doing their own groups. They really very much walk beside the service user, so they won't just be referring and just be making links. They will actually be going with people, perhaps to a housing appointment if needs be, or going with them to a meeting at a particular group. So we see them as far more an active participant in the community with the service user. We specifically want the voluntary sector because they have that unique perspective on the community and are far more connected to the communities than sometimes sort of us in the NHS can be. So that's sort of the difference there, I think, if that makes sense. And I agree with you with regards to housing. I mean, this is one of the many reasons why this neighbourhood model was set up, really, because we absolutely understand that it's the social issues, it's the social determinants which are huge factors in someone's mental health. So that's one of the reasons why this has been set up. In terms of doing direct training to housing, that isn't something that we've actually done. We have a joint housing protocol with Hackney Housing, and we have regular meetings with Hackney Housing as well. That's something that we've reviewed about 6 months ago. So we do have close links there. We also have housing who come into our ward discharge meetings, but there is a plan to get housing officers coming directly to our neighbourhood meetings. But I think you're absolutely right. We do need to work a bit more closely and offer some training to the housing officers. I think that's something we can take forward.
Yeah, I think it's a very good idea. Councillor Snell?
During my early time on this committee, we did a survey into community mental health support, and had a lot of presentations from Mind, and also learnt about the IAPT services run by the Homerton. I haven't really heard about those in tonight's presentation, so I'm wondering how exactly do those existing services fit in with what you're providing? Do you refer people coming through your pathway onto those IAPT and community wellbeing services?
Andrew, go on.
Oh, sorry, no, I was going to talk about IAPT. So we sit on the Psychological Therapies Alliance, which is something that we chair, and in that alliance we have all of our partners, including IAPT there. We are trying to work closely with IAPT so that they can be part of our neighbourhoods teams as well. We want them to try and sit on our neighbourhood meetings or weekly meetings. So there's work in progress with IAPT. It's challenging given that it's a different provider, but we're collaborating ever closer. Particularly our psychotherapy department is working much more closely with them at the moment.
And the other one is the Mind Wellbeing Network that we've had.
So it's the Mind Wellbeing Network that's hosting our community connectors. So we have regular meetings with Vanessa, who's the Mind Chief Executive, and it's the Mind Wellbeing Network and the various voluntary organisations within that actually are employing our connectors. So we have very, very close links with the Wellbeing Network, and we've been working with them also to offer some extra support during the pandemic as well for those people that aren't open to ELF. The Wellbeing Network have been part of that. So there is a decent collaboration there with them, I think.
Thank you.
Thank you. One for Paul, if I can. I mean, obviously Tracey's not here, but a year or 2 years ago, as part of the estate strategy, one of the active discussions was possibly about moving the mental health beds out of the Homerton, possibly to Mile End, possibly with some arrangement that the Homerton might get more surgical capacity. In lieu of that, your argument at that time being that would enable you to create a sort of a more specialist mental health hub at Mile End. Is that still under discussion in any way? Is that partly what the move of the old people out of Mile End is about, or not? Or is that something that's somewhat fallen by the wayside?
First of all, the move of the older people out of Mile End, no, that's not related to that at all. That was about care for that care group, and in terms of the temporary nature, that was about creating the COVID secure space on the Mile End site in the short term. In terms of inpatient estate for mental health for Hackney, the putative plans that we did indeed discuss a couple of years ago haven't, given COVID and so on, progressed. And so that's not a discussion that has been particularly live. What I would say, to be honest, is that there is a discussion that we do need about how to create really fit for purpose inpatient estate for residents of Hackney. That really does work for residents of Hackney. And I say that because some of the provision that we are in, we do need to renew. We do need to make sure that we do have a plan to be rebuilding. And so I think there is something there that we will need to revisit. What I'm not saying is that there's a plan under discussion to do one thing or another, but I do think we need to really seriously start to revisit how do we make that estate fit for purpose? How do we create a really top quality estate for the residents of Hackney? Because at the minute, some of our wards in Hackney still have, for example, shared bathroom facilities. And if you obviously link them into a COVID environment, or never mind a COVID environment, but there's the experience of the last few months, it's really not suitable. If we're thinking ahead, we do need to do something to be replanning. So that was my reason for signalling that in the paper, Councillor. It wasn't that there's a definitive plan under discussion, simply that there is something we do need to pick up there, because people in Hackney, having inpatient care do I think need us to have a better, more developed plan for how we're going to improve the estate.
Thank you. I mean, I think certainly that, again, that's something that would be, depending upon what plan came out, if anything comes out, that's certainly something that could engender a lot of public interest, and so something we need to, I think, be aware of and be consulted on. I think clearly, I mean, I recall from several sort of training events by the King's Fund, there's clearly a evidence base about enhanced clinical outcomes for certain surgical pathways, about consolidation. I can't recall, but I'm not 100% sure that evidence base is as strong necessary when you have a mass consolidation of say mental health services, and of course you've got the downside then that you're moving people far further away from their community. So the dynamics of, as I've always seen them, is slightly more complicated than on a surgical, as it were, merger. So yes, I can see that becoming, if you could just keep us updated.
Certainly.
As that goes, that'd be much appreciated. Very quick, Councillor David, last question, and then I'll wrap this item up.
Yes, thank you, Chair. At the beginning of the session, Councillor Hayhurst raised an issue with regards to Homerton in terms of some speculation that some patients might be charged or being charged. What's the situation with Elft? Is that something you need to go away and check?
Just to clarify, I think what it was that I think for GP practices they were being asked to show ID.
Oh, okay. So
I mean, I guess the question would be: are there any ID access barriers?
Okay. Yeah, sorry, I mixed up. Yeah.
Yeah. So we will go away and check to 100% confirm this, but as far as I'm aware, certainly no.
Okay.
Yeah.
Thank you both very much. That nicely finishes this item on time. Very much appreciate the completeness of your reports and your answers to us. So thank you very much indeed for your attendance today, both of you. Thank you.
Thank you.
With that, then I'll move on to item number 10, which is the redesign of the home care service. We're joined by Helen Woodland, who's the newly in post Group Director of Adult Health and Integration. We've got a report in the pack. This is a significant new recommissioning exercise for a contract or for work that spends about 20 million a year on it and involves towards 1,200 people. So Helen will give us a brief overview and her thoughts as to where that re-procurement is heading, and then I'll open up for questions. Helen, over to you, please.
Thank you, Chair. So speaking to the report that you've got, just to give a bit of an overview, clearly a very significant service for adult social care, a significant service for the council, money in terms of the number of vulnerable people who use this service. I think it's worth putting in context that this procurement has been slightly delayed due to obviously COVID and also the impact of cyber. The work has been happening during that period, but we haven't been able to do as much engagement as perhaps we would have wanted to, because obviously the people that we wish to engage with are some of those who would have been at most risk. So having done a fair amount of work to look at a model, what this paper does is put forward at a relatively early stage for comment and questions from the committee what we think the proposed model will be. It is again worth reiterating it's an early stage. We have further engagement that we need to do. But the type of model that we're looking at as set out in the paper is to move to a neighbourhoods model. And this, of course, is to help us align with the wider neighbourhoods models and the 8 PCNs. But we are not proposing that we would have 8 separate home care lots. We are probably looking at 2, possibly 3 lots. And that's to give our potential providers the economies of scale, but also to give them a geographical patch that they can work in and build those relationships. I think that's probably all I wanted to draw the conclusion to at this point. We're very happy to take questions.
Okay, are there any, Cllr Adams?
Yes, I just, there are too many jargons, and I just hoping that you can clarify the difference between zone, patches, and neighborhoods. So, you know, just please explain those, what do you mean?
I'm sorry, Chair, I couldn't hear the questions.
The difference between zones, patches, and neighbourhoods.
Right, fine.
We don't know what it is.
Can you break them down for us? What?
So neighbourhoods refers to the model that both health and social care are trying to develop, which works around the primary care networks, and that's how we're trying to organise ourselves to be coterminous. Zones is what we're talking about in terms of how we would split up Hackney geographically to create geographical areas that incorporate one or more of the neighbourhood areas. And patches, apologies, it's just an interconnected, interchangeable term, and we should have probably stuck with either patches or zones.
They're the same. So in other words, patches or zones is how you sort of configure the service around the neighbourhoods.
Yes.
Fine, I'm with it. I mean, what scope here is there to insource, and what are the barriers to doing so?
So we looked at insourcing as per the council mandate, and I think one of the main barriers, if we're being completely honest about it, is money. So it costs us significantly more to deliver home care as an in-house service. So to give you an idea, the hourly cost for us to deliver a home care service in-house would be approximately £28 per hour. When we purchase it, it's about £18.50 per hour. So it would add, I think, about £4 or £5 million a year to the adult social care budget, which obviously we would then have to find elsewhere on top of any additional efficiency targets we already have. Having said that, the other challenge is that one of our Care Act duties is to maintain and promote a stable market. So we do have to consider the stability of the market as well as one of our duties when we're looking at how we provide these services.
Thanks. And can you just sort of break it down for us? Because of course now we are a living wage borough and having to pay, say, living wage to outsource staff on the home care contract. What is it that adds that extra £10 an hour? Is it pension obligations? Is it extra management costs? But then again, a private provider has got a profit margin that they wouldn't be having if we brought it in-house. So can you just explain where that £10 comes from? How's it made up?
Yeah, so it's essentially it's the on costs associated with the pension, which makes it significantly more expensive for us to deliver.
Okay.
Just Chair.
And Cllr Plouviez.
In care homes, the cheaper cost paid by the councils is largely supported by the private payers, and I wondered whether that was the same in private agency care. So the whole market is distorted by private people who pay privately. Is that true? Could that be adding to the differential?
No, you're absolutely right. In care homes, that is an issue. It doesn't apply in home care. So the majority of home care that is purchased by the local authority. There is a very small amount of home care that is purchased privately. And that home care that is purchased privately is usually from specific agencies that cater to self-funders, not necessarily the same agencies we fund. So that isn't a factor that skews the price costs in relation to home care. It absolutely does in relation to care homes.
I have to say I'm very surprised, given that my personal experience of that would be quite different, but I'll take your word. Maybe it's different in Hackney.
Councillor Snell.
I mean, this was bound to be the issue that would concern us, given the overall direction of insourcing on this council. And it is an area of concern. It would seem to me that home care services, basically, you get what you pay for. And in terms of keeping people COVID secure, in terms of continuity of the carer relationship, it is better in a more secure employment environment. What I wonder, given we have on a number of occasions had to bail out individual providers of these services, is there not capacity? Because you also say there's a lack of existing management expertise in the council. Is there not scope for setting up an in-house service to act as a quality barometer against which other services can be monitored, and also as backup if any of those private providers fail, that we've actually got the management resource to step in quickly and put things right?
So I think they're interesting points, and I'll probably take them slightly separately. So I think the issue of quality is a very interesting one, and the council's role in quality is an interesting one. One of the reasons for wanting to move to the patch-based, zone-based model is so that we have fewer providers that we can work more closely with, and specifically allow us then to develop stronger partnerships and relationships and to deliver more training and support to them. So for example, one of the things that we would be able to do that we struggle to do with the volume of providers we currently have is to work with the staff to support them to perhaps develop occupational therapy assistant qualifications, so that they can deliver over and above the current offer that they do. Similarly, one of our ambitions is to work with our health partners going forward to look to see what tasks potentially we could train and support home care workers to deliver that perhaps currently community or district nurses are delivering. So again, trying to achieve that continuity of care, that consistency of the person going into someone's home. I think in terms of the points you make about stability of employment, we are already signed up to the Unison Ethical Care Charter, and we would expect everyone we work with also to do that when we recommission. One of the things that we do currently, and we will continue to do, is to work with providers to reduce, for example, the amount of 0 hours contracts that they have. That is something that they are better able to do if you give them more stability of work and a more consistent number of hours, because they're better able to plan their workforce and offer those conditions. So I think there are a number of ways that we can achieve those aims, and I think there is a fair challenge around what then the role of adult social care and the wider health and care partners is in supporting quality in those providers.
And Helen, if you're signing up for 2, obviously the risk is you haven't got the multiplicity of choice that you have with 8. Should there be a problem? How long would the contracts be with the 2?
So we're looking at 5 + 1 + 1, I believe.
As in two break stages?
Well, so bearing in mind the procurement will allow us, if people are not meeting our quality standards, to terminate the contract and reallocate it. We also have, and we are planning to have, what's known as an approved provider list. So that is, in a sense, a backup list of providers that meet our quality standards and that work to the standards that we want them to. So where, for example, in a patch or a geographical area, someone does not, for whatever reason, want to work with the 2 home care providers that are allocated that patch, we have alternatives that they can choose from. It also gives us a group of providers that we can support and develop if, for example, there is a market failure, so that we're never left in the position that we can't provide the care that is required.
And is the budget envelope you're being allowed for this recommissioning the same as was previously the budget envelope of the old commissioning for the 8?
So it is, but based on the principle that we are a demand-led service. So our budget envelope as such is that anyone who has an assessed eligible need under the Care Act must receive care. That's our statutory duty. We can do nothing about that. So referring to some of the other conversations that have happened this evening, the development of more kind of preventative work, working with our partners in a neighbourhood way, is incredibly important to help us manage that demand going forward. But we will always meet the care needs of anyone who meets our eligibility criteria. That's fundamentally what we have to do.
Fine. I mean, but the key point is you're not going in with £5 million less to procure these.
No, absolutely not.
Fine. Okay. I think I'm going to, and I'm looking around. I'll draw this to a close. We want to bring in the final item, a substantive item in terms of COVID update. So thank you very much, Helen, for that update. Item 11, we've got Siobhan here, and I can see Chris. Thank you very much. I'm not sure, I did hear a whisper that you meant to be on leave this week. So if you have joined from leave, thank you very much. We've got a helpful, succinct presentation as to where we are. Chris, I'm not sure if you're able to engage. Just before I go to Siobhan on the vaccination, I mean, I've been looking every day at the update for Hackney. I think we're 200% up in a week. That's virtually a tripling of numbers. 43 in 100,000. It's heading north. Can you give us any overview or update?
So I think some of the press reports on the increases were not quite 100%, but you are right. We are heading in the wrong direction. Unfortunately, not just in Hackney, but across London as well. There is a degree that this was expected as soon as we do start reducing any of the social distancing measures. there is very clear evidence the Delta variant, what used to be known as the Indian variant, is now both the most dominant variant. So any new COVID cases are now assumed to be the Delta variant, and it is more transmissible. I think where we are at probably in London is slightly different from the rest of the United Kingdom. You would have seen, no doubt, all the press reports about the vaccination programme rolling down the ages, and obviously in Northern Ireland and Wales and other areas, they are able to vaccinate now the over 18s, which is really welcome. Where we are in North East London is slightly less rosy. We're about 330 vaccinations behind the plan, where we should be, and there is now quite a lot of work that's being undertaken to identify and undertake some surge vaccination events. And we have been doing some smaller versions of those locally with great deal of amount of success at Gillett Square, and also very kindly the Homerton have offered St Leonard's site as well for Thursday vaccination. So there is a lot of activity taking place to try and increase the vaccination uptake. I think the message really around COVID at the moment is it's test, 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 and it's follow absolutely the current arrangements, which are work from home where you can, and social distancing. And as soon as you have any symptoms, it's self-isolate and it's test with a PCR test. And clearly the expectations that the 23rd of June and the announcement probably next Monday from the Prime Minister may loosen a lot of those restrictions is not particularly in keeping with where the current figures are heading. The good news, I think, again, and this has been played very strongly in terms of why to continue with the opening, is the hospitalisations have not yet reached anything like the levels we've seen previously. The only word of caution, I think, for London, where London's slightly different from elsewhere, in North East London, for example, it's over 70,000 people who are essentially unvaccinated and most at risk. So this is cohorts 1 to 6, so clinically extremely vulnerable and over 65s. Now, although we're not seeing those figures yet locally in Hackney, because most of the new infections are in the younger age group, which is probably what you'd expect with more socialising and perhaps less stringent adherence to social distancing. But very quickly, if the R rate, which is now above 1, continues to increase, you will get people who are unvaccinated, and even if they're vaccinated today, it takes some time before they get the impact of that vaccination. But you will see those people potentially starting to appear into the acute hospital beds and putting that pressure on the NHS. So I think in many ways we've got everything to play for to see what's going to happen nationally. London is in a slightly different position from the rest of England and the United Kingdom. The work by colleagues in the NHS on undertaking hundreds of thousands of vaccinations locally and over 1 million in North East London is incredibly welcome, but we still have got, I think, a number of challenges ahead of ourselves. So great news on some of the mass numbers, a little bit more to do in terms of targeting the vaccination to communities most at risk. And as you rightly say, the figures are going definitely in the wrong direction at the moment.
But Chris, just before I bring Siobhan in, I mean, if I've understood sort of the government dashboard when you type in the Hackney postcodes, whereas nationally it's about 76–77% of people nationally have had their first dose, and about 53 have had their second dose. In Hackney, it's about 23 that have had 2 doses, and about 45–46 have had 1 dose, along with Tower Hamlets, we're the lowest in the country, if I've got this right. And with a highly transmissible variant, we could be one of the worst hit places with this wave.
I think
that's too grim.
So the difficulty, I mean, quite rightly, the Joint Committee on Vaccinations and Immunisations took an approach which was based upon vaccinating the most at risk first, recognising the limited supply. So it's not always as straightforward as just comparing kind of places and places. You need to look at the rates of vaccination, and really it's looking at cohorts 1 to 6 and 1 to 9, but 1 to 6 are those particularly at risk, and that's where we've actually had lower numbers overall because our age population tends to be younger. But our uptake is slightly worse because we do have vaccine cautiousness in a number of our communities, and we know across the country that especially people from Black ethnic minorities have a lower uptake of the vaccination. Now that's not unsolvable, and the work that we've been doing in partnership with community organisations, the outreach work, you know, it is possible to make sure that people are given trusted information and confidence to then go forward and book the vaccinations. What then often happens is, as the government reduces the age of cohorts, you then get the effect that the younger people who are really very keen to get vaccinated will go on and will essentially book as many of the appointments that are available. And then what you have essentially is a kind of crowding out of people who may be slightly more cautious, not so digitally enabled as others. And that's why we've been looking at how these very low threshold events where you can literally walk up and get vaccinated. And we're really keen to explore more of that in community pharmacies, and potentially expanding some of the other sites like the Homerton Hospital may also offer us another opportunity to do some surge vaccinations. So I think when you're comparing kind of the vaccination uptake, the big figures can hide the real priorities, and the real priorities really is that 17,000 unvaccinated. And it has taken a while for us to get all of the positions, in place, the work with the community organisations to get the insight. And that's now what we are working very strongly in partnership with our NHS colleagues to deliver on. But as I've said, where you're seeing now the COVID cases, in many ways, COVID infections, setting aside long COVID and noting the discussion there, that does take place in all the age groups at different rates. But really, in terms of the really severe hospitalizations that take place, it's very much the older and it's the people who are clinically extremely vulnerable. And what you're looking at across the country is fairly good vaccination uptake rates for there, but then not only in North East London, but other areas with deprivation and with more multi-ethnic communities, the vaccination rates are lower. So we have got that area that we do need to focus on, and that is the work that's taking place locally.
Thank you. Siobhan, just before I see Councillor Snell, Siobhan, do you want to add anything before I bring in Councillor Snell?
Well, I don't think so, to be honest. I think Chris has done a very good job kind of setting out the context, really. But I guess, you mentioned the third wave planning at the beginning of the session, although Tracey wasn't able to, get the tech to help to get to that question. But really, that's what we're having to focus on, is what might we have to do differently in City and Hackney because of our issues with less uptake, because we won't have a sort of coverage from a national lockdown necessarily in a further wave in the way that we might need to give out specific advice, really. And it's frustrating because we are all working so hard in terms of trying to increase that vulnerable cohort in particular. But there's just so many factors that play in, and also as Chris said, the kind of the way that the rest of the programme then comes online at the same time is just the volume and the ever increasing scale of it. Really, it's really hard to keep that focus alive all of the time. But we are very much focused on it. Is all I could say, really.
Thank you, Councillor Snell.
I have always been concerned, partly from my experience when those first cohorts came through at the vaccine centre, about whether we were able to get to the carers and help the carers get vaccinated, because obviously they are often a potential vector disease and often have multiple vulnerable clients. Looking at these figures, if I'm reading them correctly, the incidence of vaccinations in domiciliary care staff is abysmally low, and I wondered if there are any plans, now we're allowed to vaccinate younger age groups, to particularly target that part of the population so they don't become the vector for disease to the older people that we're most worried about.
So just to be clear, for domiciliary care, there are 1,600 members of staff, 37% 1 dose, 6% 2 doses.
Yes, Chris, did you want to answer that? Because you've been doing a specific piece of work on that.
I'll start, and then Helen may want to add anything. Yeah. Just in terms of those care staff, they are obviously very much at the front line and rightly defined as that. So they have been eligible for vaccination right since the very start of the pandemic. Sometimes the national messaging does focus almost exclusively on NHS, and some people don't necessarily understand that frontline is anybody providing health or social care, very much that sort of face-to-face client-facing service. So they have been eligible for vaccination. I think there has been an element of, if you're looking at who actually provides the care, it very often is staff from ethnic minority groups. And so we do know that there is a degree of cautiousness amongst that group. However, we have been able to be very successful by taking a very clear focus for the older adult care homes to actually get vaccination rates up. And that has been the focus across North East London and many other areas, is to ensure, because they are providing care for the most vulnerable for COVID complications. But that's not to say that we haven't essentially identified, as you rightly say, that we want to at least double, if not increase more, that vaccination coverage for all of the care workers. Now, the kind of work that we're doing is very similar to the work we've done in the adult care homes, understanding where the barriers are, potentially incentivizing the providers as well as the staff to actually attend the vaccinations by paying for their time, making sure that it's seen as part of your work employment, recognizing that there is still quite a lot of hesitancy and cautiousness. A lot of those staff will actually be in a reproductive age, so under 40, making sure that the offer for Pfizer is as easy as possible, and then looking to understand some of the barriers, which may be about how do you actually get a vaccination. That whole issue of each time you reduce an age, the system essentially gets booked up. So we are going to be looking to do some engagement sessions with the staff. We've already undertaken some questions and answers with the provider forums, and then ultimately it's about taking the vaccination as close as possible to the staff and making it as easy as possible for people to engage. That could involve community pharmacy. We are looking to expand the number of community pharmacies that offer vaccination, but ultimately may also be actually a mobile vaccination service going into where there's been vaccination. There's a lot of evidence from the work that's been quite successful in flu vaccinations in health and social care about the fact that you need to keep on this. You need to have a very clear aspiration, a metric, encourage the providers, and then perhaps cajole the providers. And ultimately, the government is still considering whether it does want to make this compulsory. I think that will be hopefully the very last step, because I think, again, for people who are hesitant and cautious and have a belief system that says, that the government is out to do all sorts of things with you with COVID vaccine rather than protecting yourself and your family, it plays into that narrative. So you're absolutely right to highlight it. It is an area that we do need to improve. There has been examples from across North East London where other areas have focused on this and very quickly turned this around, and we're very committed to doing that. Just, Helen, if there's anything you wanted to add.
I think probably just to reinforce everything Chris has said, we're very well aware that the number in home care is not where it should be. It's our single biggest area of concern. Within the council, we've employed a project manager specifically to work with partners and with our care agencies to support uptake. We are trying a number of different approaches, but I think, as Chris said, that there are multiple complex reasons why people are vaccine hesitant, and it does take quite a lot of concerted work, particularly with that group of.
Oh, we've lost you temporarily, Helen. Yeah, we've lost you, Helen. I think. Okay, I think we were coming to the end there anyway. So I think. Councillor Adams, go for it.
Yeah, this one is just about if there's any update on targeted testing in Shoreditch and Dalston.
Yep. Okay, I'll make that the last question. So, Chris, if you could just give us an update on the target testing in Dalston and Shoreditch.
Yes, so that testing has now concluded. Essentially, when we were probably one of the last areas that will be doing it this way. What you're essentially looking to do with target testing or surge testing is to do an awful lot of testing in an area in order to identify the variants of concern. Since we've done that, there's been some welcome and less welcome changes. So with welcome changes, are all positive PCR tests in London are now sequenced for variants of concern. That didn't used to be the case. And that was one of the key reasons for doing the surge testing. So we have now concluded the surge testing. We're awaiting the results in terms of the variants of concern as to how many have been identified. You've seen in the data pack the kind of presentation. It does take a number of weeks after a positive test has been identified on a PCR for that then to be sent off for sequencing. So we are awaiting to see whether variants of concern have been identified. But in the preceding, in the 2 weeks since we've essentially done the that testing in Dalston and Shoreditch, the Delta variant has now become the dominant variant across the UK. So essentially any new positive cases are now assumed to be Delta variant, which shows how quickly things can change with variants of concern. And so why public health is asking for a degree of caution, and certainly for the next 2 weeks, and potentially if lockdown measures are pushed back a little bit further, that whole measures around get vaccinated, social distancing is important. The other thing I forgot to mention, and apologies, was just in terms of the real importance of the second dose vaccination. So it's going to be one of the communication messages that we're going to be majoring over the next 10 days or so. Really important that people do get that second dose vaccination. If you had side effects from the first dose, it's likely the side effects are going to be less for the second. And also, very, very, very few people have any serious side effects from the second dose. If there is, for the very small number, it's nearly always the first dose. So there should be confidence that people will be able to come forward for the second dose. But again, it's making it as simple as possible. And then for a variety of reasons, people have gone beyond 8 weeks or 12 weeks. It's making it clear that people can walk into a vaccination centre and get that second dose. So second dose is really, really important. And that's going to be one of the issues that we're majoring on in our communications in the next few days.
Okay. Thank you, Chris. With that, thank you as well if you've joined us from leave. We appreciate that. So I think I'll draw it there because we're slightly over. So thank you very much for the update we've had, and I depending on where we are, we may well have to revisit a further update in July. Item 12, meetings of the previous meeting. Can I take those as read, please, colleagues? Thank you. Work programme is set out, 13. I haven't been notified of any other business. So with that, I'll close the meeting and thank you all for attending.
Thank you.
Thanks. Bye.